Assalamualaikum and hi everyone. I hope this finds you in a good condition. My name is Marina and I'm going to do a presentation on AP scapular projection. So we're going to do an antero-posterior projection. So the radiographic outcome should look like this. So we start off with the first criteria in evaluating an radiographic image, which is the projection and positioning. We're going to go through first projection. AP scapula and AP shoulder projection looks almost the same. So what criteria that differentiate them? We're going to go through with AP scapula first. So AP scapula. So why this is an AP projection? This is because first, humeral shaft demonstrated above 90-degree abduction. Centering ray is pointed at mid-scapula. Third, neck of scapula is in sign. So between AP and lateral scapula, AP shows the best demonstration of the neck of the scapula, which is here. So fourth, supraspinatus fossa is in sign. So why this is a scapular projection? The anatomic structure in sign includes the glenoid cavity, acromion, scapular body, and the inferior angle. Next, we go through with AP shoulder. Why this is an AP projection? First, superior scapular angle superimposed with mid-clavicle. No humeral shaft abduction. Superior scapular body at the center of exposure. So why this is a shoulder projection? This is because exposure field includes glenohumeral joint, clavicle, proximal third of humerals, and superior scapula. So you can see here, the AP shoulder only includes the upper parts of the scapula, while the AP scapular projection includes the whole part of the scapula. Let's check this radiograph. This is a radiography of AP projection of the scapula. I said so because the glenoid cavity, acromion, scapular body, and inferior angle is in sign. The neck of the scapula is in sign, and the supraspinatus fossa is in sign. Next, we check for the positioning. First, the humeral abduction. Humeral abduction above 90 degree. When arm is abducted, lateral scapula is drawn from beneath the thorax cavity and the glenoid cavity moves superiorly. It needs at least 90 degree abduction. So when you abduct patient's hand above 90 degree angle, it will pull the scapular body away from being superimposed by the thoracic cavity. So what happens if you don't abduct the arms at all? So less than 60 degree of humeral abduction will result in superimposition of the inferolateral border of the scapula and the thoracic cavity, and the superposition between clavicle and the superior scapular angle. Second, shoulder retraction. In normal AP positioning, scapular body is placed at 35 to 45 degree angle with the image receptor, which result in transverse or longitudinal foreshortening. This can be reduced by elbow flexion and hand supination. By placing pressure on lateral aspect of the scapular body will result in it moving posteriorly and scapular body foreshortening will be reduced. Poor retractions is identified by excessive foreshortening. Glenoid cavity is demonstrated somewhat at the end. Mid-coronal plane tilting. If the superior scapular angle is less than 0.6 cm inferior to the clavicle, means the upper MCP is tilted anteriorly or forward. As you can see at the example here, the superior scapular angle is located above the clavicle, so it is tilted forward. But if the superior angle is more than 0.6 cm inferior to the clavicle, it is tilted posteriorly or backward, as you can see in the example. The superior scapular angle is located way beneath the clavicle. So the correct positioning is the superior angle of the scapula should be slightly superimposed or right underneath the clavicle. Let's check this radiograph. The positioning for this projection is wrong. This is because the inferior border of the scapula is superimposed by the thoracic cavity. The humerus was not adequately abducted. So to improve this, the humerus of the patient must be abducted into a 90-degree angle. Second criteria, alignment. So first, alignment between patient and image receptor. It is correct because the superior is the same length as the inferior. The left side and the right side is in the same length. So second, alignment between patient and collimation. It cannot be determined because there is no four borders of collimation. Third, the alignment between image receptor and the collimation. It cannot be determined because there is no four borders of collimation. The centering ray for this radiograph cannot be determined because there is no four borders of collimation. And the standard centering ray for this radiograph or for this projection is at the mid-scapula or 2 inches inferior to coracoid process and 2 inches medial from the lateral border of the patient. Third criteria, collimation. At the superior border, it should include acromion, clavicle, and coracoid process. At the inferior border, it should include inferior angle, lateral border, and vertebral border. And at the lateral border, the structure should include lesser tubercle, glenoid cavity, and lateral border. The fourth criteria is exposure factor. So first, contrast. The bony cortical outline of the thin structure, which is the inferior angle, can be seen. The bony cortical outline of the thick structure, which is the coracoid process, can be seen. Therefore, the cavity used is adequate. Next, density. The bony trapecular pattern of the thin structure, which is the scapular body, can be seen. The bony trapecular pattern of the thick structure, which is the coracoid process, can be seen. Therefore, the MAS used is adequate for detail and density. Fifth, marker. Only plumbar marker are acceptable. So there is evidence of an anatomic marker shown in this radiograph, correctly placed on the right side of the body and placed with correct orientation and not superimposed with any region of interest. Sixth criteria is the aesthetic value. So the image receptor size used is 24 times 30 cm in lengthwise, and there is no signs of artifact in this radiograph. The last criteria is name. The patient's name, identification, date of examination, and place of examination. So the patient's identification, date of examination, place of examination were not included in this radiograph. Therefore, it can be placed at the bottom left or top right corner of the radiograph as long as it doesn't superimpose with any region of interest. As a conclusion, this radiograph is rejected because there is no identification of patient were included in this radiograph. Second, the positioning of this projection is incorrect, causing superimposition of region of interest with the thoracic cavity. This is the resources I used. If you wish for further information, please go check the website and the books. That's all from me. Thank you.